Hi guys, the next topic we're going to study is infective endocarditis, and first up would be organism specific approach with respect to native valve endocarditis slash a prosthetic valve endocarditis. If he says native valve endocarditis, don't straight away answer a Staphylococcus aureus, because in majority of questions it's going to ask you with respect to community acquired native valve endocarditis. Then your answer would be given as Streptococcus. However, let me say the patient was admitted into the hospital. There was a central line in place, and post this central line insertion, he got an infection directly into his bloodstream. He developed a Staph aureus sepsis, and then ended up with a Staph aureus induced damage to the heart valves. So he is either going to say the word hospital acquired, or he's going to use a more common term, that is healthcare associated infective endocarditis. That's native valve endocarditis. If asked, only then the answer would be given by you as Staphylococcus aureus. Now, next is going to be prosthetic valve endocarditis. This guy underwent a valve replacement surgery, and the answer in this case will depend on duration. The durations that would be asked to you would be either within the 2 months of he got operated. I mean, it could either be an intraoperative contamination of the operating field, or it could have been post-operative. But these are the three scenarios that can be given to you between the earlier part, that's the first 60 days of surgery, or it could be with respect to after 12 months he got procedure done, maybe in the starting of 2022, and now in 2023 or 2024 patient has come to you, or it could be intermediate as well. For the first two, when I ask this in a live class, the usual answer that I get is Staphylococcus epidermis or Staph albus. Well, the answer to be given here is a more broader term, that's CONS, which is coagulase negative Staphylococcus for the first two scenarios, that's early and the intermediate one. But if it's going to be after 1 year, then the answer is going to be given as identical to what you read for SABE, that is subacute bacterial endocarditis. You see, traditionally in earlier times, they always used to terms like acute bacterial endocarditis is Staph aureus, SABE is going to be Streptococcus viridans. But as of now, you will notice that with the changing landscape or the changing data with respect to infective endocarditis, the terms are used more specific with respect to whether the original heart valve got infected, or whether it was an artificial heart valve deployed that got infected after a variable period. I also said there's a changing landscape. What I mean is that in earlier times, rheumatic heart disease was common, but the incidence of rheumatic heart disease is gradually decreasing because of easy availability of antibiotics. Obviously, it's very less in Western countries. It's even less in developing countries as well. So when it comes to valvular lesion, as of now, one of the common valvular lesions that would be found in an American patient is aortic stenosis. If you go through the video valvular aortic stenosis, I've explained senile calcification of the aortic valve. This particular gentleman who was having a senile calcification of the aortic valve, we did a procedure that's called as transcatheter aortic valve replacement. Either the term used is TAVR, that's a transcatheter. We take a femoral approach and we deploy a new valve. The new valve is deployed over and above the old calcified valve. We don't remove the old calcified valve. Removing that would be risky. There would be calcified fragments going over to the brain. So we deploy a new valve over the damaged calcified valve. So we call it transcatheter aortic valve replacement, or in some books may be written as TAVI, that is transcatheter aortic valve implantation. I repeat again, there could be two terms that are used interchangeably, TAVR and TAVI. It is transcatheter aortic valve. In one of them, either the word used is replacement or is an implantation. And because you're deploying a new valve in this case, therefore the term subsequent to that was prosthetic valve endocarditis. Now, in this case, the tendency is to answer Staph aureus. Well, it merely is the answer. It merely is the answer. But in the exam, they always love to give two close options. You guys are brilliant chaps. You can rule out two options very, very easily. But when it comes to those close options, what I want you to remember is that Enterococcus is slightly winning the battle in this particular case. So in case you get a question where Enterococcus is not in the options, no issues. You straight away answer Staph aureus, cool. But if both are present, then Enterococcus has a slight edge over Staph aureus when it comes to the incidence of a transcatheter aortic valve replacement and then a development of an infection there. Then is CIED. As the name suggests, this patient was having a cardiovascular disease for which an implantable electronic device was put. And usually what are the implantable devices that will be put? It could be like a implantable cardioverter defibrillator. ICD is usually put in those patients where there is a tendency for development of tachyarrhythmias. On the other hand, if a person is having dilated cardiomyopathy, suppose a person is having an alcoholic cardiomyopathy, the left and the right ventricle may not fire at the same time. Yours and my left ventricle fire precisely at the right time and eject equal amount of blood. If there is a misfiring, in a sense that the left and the right are not contracting at the same time, they could be pooling of blood in the lungs. So to make the two ventricles fire, the damaged dilated ventricles to fire at the same time, we use CRT, that is cardiac resynchronization therapy. Another electronic device that we read is a pacemaker, which is useful for patients who are having bradyarrhythmias. What I'm trying to tell you at the moment is that the incidence of infective endocarditis in devices like ICD and cardiac resynchronization therapy is higher as compared to that of a pacemaker. And well, how can you remember this epidemiological information? Is like, you see, pacemaker is put for a heart that is slow. So I am just saying the English word slow, less incidence. Let me say it another way. ICD is put for patients who are having tachyarrhythmias. Tachy means fast. I'm using the English word in fast, rhyming with higher incidence. So at the moment, one, I have told you not, I'll obviously talk about the organism because that's my focus. What's the organism that's responsible for CIED? That's a cardiovascular implantable electronic device, which could be ICD, CRT, or a pacemaker. We'll talk about the organism as well, which is standard Staphylococcus aureus. In fact, no prizes for guessing that. But the point is that he can also ask you regarding with which device the incidence would be higher. Then the point is the devices that are useful for management of tachyarrhythmias or in patients or dilated cardiomyopathy to make the two ventricles behave and fire at the same time, the incidence would be higher as compared to that of a pacemaker. And you can see that why in the question would he be preferring to ask you regarding transcatheter aortic valve replacement is because there the answer is not Staph aureus, it is Enterococcus. In earlier times, in the previous edition, we were using terminologies like IV drug user. I'll write it and erase it. Earlier, the time used was IV drug user, but in the current edition, he does not use the word intravenous drug user, but he uses terms like PWID, that is people who would inject drugs. So it's more of, I would say, considering the sensibility, that intravenous drug user looks like a much more, I would say, a less sensitive term. So instead, people who inject drugs, that's injecting drugs, either it would be, I mean, they're talking a shot intravenously, or they could be just, injecting the drug, maybe intramuscular, may not be getting a proper IV access sometimes. But the point is, people who inject drugs, the first point would be that the infection will go in the right side of the heart, because if you take a shot, right, in the cubital fossas, IV drug users would be doing, or they'll be popping any vein per se, then the infection would be going first to the right side of the heart. So the traditional question would either say right-sided endocarditis or people who inject drugs, which valve would be affected. Obviously, no prices for guessing that again. That's tricuspid valve, that would be busted, and he'll say, what's the organism that's responsible? Then the first answer in this particular case would be answered as Staph aureus, and most of the time it's going to be MRSA. So I'll write just Staph aureus and MRSA. We'll talk about the treatment of this also, because that's pretty interesting, the treatment part for MRSA. Apart from vancomycin, daptomycin, a couple of other strategies that we'll be deploying to kill the bacteria living in the biofilm that's created by Staph aureus. Now, he is going to talk about right-sided endocarditis. That's understandable, and the answer is still Staph aureus. But there is again a twist, and the twist would be that he could talk about a left-sided endocarditis. This is what I mean by left-sided endocarditis. This particular guy, he did IV drug usage, and therefore bacteria will obviously get access to the right side of the heart, but there is a window open in the heart of this patient which is allowing bacteria to access onto the left side and cause damage to the left side heart valves as well. Well, it looks very peculiar in a sense, because in our heart, there would be no communication like this that would allow the infection to go from the right side to the left side. So one simple question asked here would be that which congenital heart disease or a defect would be present in a heart which would be allowing the bacteria to go across the atria from the right side to the left side. And I think by this particular time, you would have guessed it right. It would not be AST, because AST operates from left to right, and here the infection is going from right to left. So the particular answer for the query that I put up was that this particular chap is having a PFO, that is a patent fossa ovalis, or a patent foramen ovale, and via this PFO, the infection can go. So, I mean, people without a PFO, it would not be possible, and PFO is usually associated with tricuspid stenosis. So, what I'll also do in this diagram is incorporate a bit of tricuspid stenosis to highlight, I mean, why the pressure in the right atria was higher and the fossa valis did not close after birth. Now it's going to ask you which is going to be the organism responsible here. And once again, though one of the answers that we anticipate would be Staphylococcus aureus, but here again, Harrison has mentioned, he has used terms for left-sided endocarditis. It says usual organisms and Enterococcus or Enterobacteriaceae. Along with that, he's talked about gram-negative like Pseudomonas, the nasty organism. And apart from this, even Candida, I mean, fungal endocarditis. So for fungal endocarditis, we might have to go in for surgery. We might have to use amphotericin B for these patients and 5-flucytosine. I'll talk about fungal endocarditis towards the later part of the discussion when I talk about the treatment part. But at this moment, I just want to sensitize you to those questions where the answer would not be standard Staphylococcus aureus. So let's it's not that Staph aureus, if Staph aureus will occur on the right side of the heart, it can't occur on the left hand side. True. I mean, if the infection will go on the right side and cause a problem, it can cause a problem in the left side also. So when Harrison is written a very, a broad statement that saying that apart from the usual organisms, these are the ones which are encountered. So I'm just trying to quote the textbook here for Enterococcus for left-sided endocarditis. For the traditional questions where Staph aureus is the answer is CIED, a cardiovascular. I mean, he's having an electronic device in the heart. It could be any one of them. And I already told you the incidence of infective endocarditis in those devices which are used for tachyarrhythmias is higher as compared to that for bradyarrhythmias. And then once again, where answer is not Staph aureus and Enterococcus just wins the match at the very last moment is TAVR/TAVI. We don't remove the old calcified aortic valve. And then anyway, I told you about situations like cons for prosthetic valve endocarditis. So the organism specific approach has to be rock solid. This is, I think, a repetition of your microbiology component. And once you've done that, then we are ready to face a couple of more issues with respect to this topic. Now, the issue that I would like to raise next is with respect to incidence of infective endocarditis, and the logic to be used for this is that the incidence is directly related to the pressure gradient that might be present in any valvular lesion or a congenital heart disease. Let me just write down a couple of valvular lesions before you, that is mitral regurgitation, mitral stenosis, aortic stenosis, and aortic regurgitation. I could have written lesions on the right side of the heart as well, but the point is right side of the heart would be having lesser pressure. So anyway, you would have been in a very comfortable position to rule out the options related to right side of the heart. So I've deliberately taken lesions, all of them on the left side of the heart, and the question will say which of the following will be having highest incidence of development of infective endocarditis. Then the logic to be used by use purely mathematical. Now, if you look at the data here, you see mitral regurgitation will operate at a pressure gradient between left ventricle minus left atria, whereas aortic stenosis will operate on a pressure gradient between left ventricle versus the aorta. You see aortic pressure would be 120, left ventricular systolic pressure would be around about 120 or a little more than that. But the point is, during valvular aortic stenosis, the pressure gradient, obviously in aortic stenosis, there's a compensatory hypertrophy. So the aortic left ventricular pressure has to exceed the aortic pressure for the blood to go out, but it would be a difference of only few points. Like let me say, due to left ventricular hypertrophy, the valvular aortic stenosis will cause a compensatory LVH, and therefore LV pressure instead of being 120 can be 125, 130 to enable the blood to go out. But still, the difference between the two would be hardly 10 millimeters of mercury. But if you compare LV minus LA pressure, it's a huge difference. Guys, it's not aortic stenosis or aortic regurgitation, it's mitral valve lesion that would be responsible. And how did I rule out? Option number B and D is mitral stenosis operates during the phase of diastole. Aortic regurgitation also operates on the phase of diastole. So anyway, I can rule out those two options because during diastole, the gradient is anyway lesser. Gradient is max in the heart during the phase of systole, and there are two lesions that operate in the heart during the phase of systole, that is mitral regurgitation and aortic stenosis. And therefore, if the question says which of the following has the highest chances of development of infective endocarditis, I could have straight away asked you cram the data mitral regurgitation, but I've tried to give you a mathematical direction. The point I'm trying to make is that mitral regurgitation will operate during the phase of systole. Aortic stenosis will also operate during the phase of systole. So systolic pressure gradients are higher than those of diastolic gradients. So therefore MS and AR are out of the discussion. Between the first option and the third option, which you can currently see on the slide, MR operates at a higher pressure gradient, and this also gives credibility to the fact that why to a large number of questions answer is mitral regurgitation. For example, I say which is the commonest valvular lesion seen after myocardial infarction. Answer is mitral regurgitation. Commonest valvular lesion with respect to infective endocarditis, mitral regurgitation. Commonest valvular lesion seen in pediatric age group with rheumatic heart disease. See, in rheumatic heart disease, after 18 years of age, the number one organism, the number one lesion would be mitral stenosis. You all know that. But if he says 5-year-old kid, for the pediatric domain, the answer should be given as mitral regurgitation. So I said MR 3 times, post myocardial infarction, rheumatic heart disease in a pediatric domain, and obviously after infective endocarditis. Even in cardiomyopathies, usually MR is associated and it operates at a higher pressure gradient. The opposite of this will say which of the following will be having least chances of development of infective endocarditis. Then your answer would be given as atrial septal defect. Why that is so is because AST is a low pressure shunt. The pressure difference between the left atria and the right atria, that's with respect to atrial septal defect, is about 4 millimeters of mercury. That would be an ultra low pressure gradient, which is why the chances of infective endocarditis will be relatively lesser. Now, what happens in patients of infective endocarditis is creation of vegetations. Those vegetations would be developing on the heart valves. What is the vegetation composed of? Vegetation is composed of platelets, fibrin, bacteria, and few inflammatory cells. I repeat once again, vegetations, what are they composed of? Vegetations would be composed of combination of platelets, fibrin, bacteria, and a few inflammatory cells, and these vegetations can embolize to distal circulation. God forbid if vegetation from the mitral valve goes into the systemic circulation, goes into a brain, it can cause embolic manifestations. Or these vegetations can go downstream into the descending aorta and compromise the blood supply or jeopardize the blood supply of some part of their small vegetations, right? So they'll go into smaller blood vessels, occlude them, and cut off the blood supply of the spleen or cut off blood supply to the kidney. So you could be having infarcts as well. So organ infarcts can develop in these patients. Septic infarcts, again, because it's carrying bacteria also, right? So septic infarcts will occur in these patients, which is the reason why during the later part of the discussion, you will see me saying words like splenomegaly or multicentric brain abscesses developing in these patients. Meningitis developing in a patient of infective endocarditis. Why? Because of embolization of the vegetations. You see, whenever there's a valvular lesion in the heart, there's a jet of blood. The jet of blood will cause damage to the endocardium, and wherever there's a damage present at that area, the bacteria can come and stick on and can cause local damage, and therefore we can be having two possibilities developing in a person. One is acute bacterial endocarditis, or the second can be written as SABE, that is subacute bacterial endocarditis. Well, what is the difference between the two is only with respect to the duration and the severity of manifestations. If he just says in acute bacterial endocarditis or acute infective endocarditis, which will develop over a matter of couple of weeks, the progression of the disease will be much more faster. There would be hectic fever developing in a patient. There is a high chances of mortality or high chances of death of an individual, and that's primarily because of the sepsis, the bacteremia, the vegetations embolizing into distal circulation that will cause problem in this patient. So high chances of death, and this would be a hectic febrile illness, high grade fever with chills and rigors, and most of the time the person will expire. In the subacute course, which will be slowly, it would span over from weeks to months. Within weeks is acute bacterial endocarditis, usually caused by Staphylococcus. For subacute bacterial endocarditis, the leading cause, as we have discussed already, and you know that from your microbiology also, is Streptococcus viridans. In this, there would be progressive structure. This has a more, a gradual indolent course, as is described in the book. Indolent course would mean that the person's suffering would be much more prolonged from a matter of weeks to months, and this results in progressive structural damage. Or let me say, if a person is having a pre-existing valvular lesion, then the pre-existing valvular lesion will tend to worsen in this patient. So cardiomegaly will increase, or sometimes the vegetations can break. Suppose there was a vegetation with respect to the aortic valve. So the vegetation can actually break off from the aortic valve and then can go into the coronary artery And you can understand if a vegetation is going in the coronary artery, it can even contribute to MI developing in these patients. So most of the time in subacute bacterial endocarditis, it's a progressive valvular damage, it's a progressive cardiac damage, there would be gross cardiac dilatation occurring, and there could be some complications also. I mean, if you have a heart dilated, if it's not functioning properly, congestive heart failure, arrhythmias can occur. Rarely it's a possibility that the person might have even a major embolic event. So major embolic event, that is development of stroke, can occur with respect to both of them. In subacute also possibility is very much there. Or I can give even a much more graver situation, that the bacteria have gone out of the heart, gone into the systemic circulation of the brain, and gone via the systemic circulation to the brain, and now the bacteria is feeding into the wall of the blood vessels of the brain, like middle cerebral artery or anterior cerebral artery, right after the first branch. Usually after the first branch of the middle cerebral artery, the movement starts branching, or anterior cerebral artery starts branching, that's where you can get this development of mycotic aneurysm. In fact, this is itself a question. I think it was a FMG exam question, very straightforward one. Mycotic aneurysm, as you can understand, I mean, it's not caused by fungus, it is caused by bacteria. Mycotic aneurysm can unfortunately rupture as well, and this could result in development of subarachnoid hemorrhage in a person and expiry. So I'm talking about a cardiovascular disease, but you can see the wide ramifications of it, that the infections can go out of the heart and can cause a death. The usual issue is acute bacterial endocarditis. Most of the time person will die. In subacute, most of the time there would be progressive damage to the heart, but rarely is a possibility that even in the subacute variety, there could be a major embolic event. The infection can go out to the brain. Therefore, hemiplegia could be described in a patient, sudden onset, focal neurological deficit, focal arm weakness could be developing, speech deficit could be developing, or as I said, God forbid, if there's a mycotic aneurysm that has developed, it can rupture at any point of time and can cause mortality in an individual. The minimum message to be remembered from this slide would be with respect to the pressure gradient part. I mean, they can give you any permutation combinations. All you need to think there is from the mathematical perspective. Even if they give you a pediatric condition like ventricular septal defect, patent ductus arteriosus, all of them are shunts which operate at high pressure. ASD operates at a lower pressure, and most of the questions he's going to mix up the valvular lesions that we get in adults with that of atrial septal defect, and he's just going to say which of the following has the least incidence of infective endocarditis, repeated multiple times, straightforward. Atrial septal defect, mainly because of a lower mathematical gradient. Now, before we go forwards, I also want to bring to your attention another very peculiar terminology, and that terminology is infective endarteritis. I was talking about infective endocarditis. No, the question said infective endarteritis is seen in. The students of mine who were attending this exam, when they got this question, I mean, they said, sir, we simply used logic. You had spoken about it, but yeah, I could just, he says, one of my students, he said, sir, I just focused on English word, endarteritis. So I thought, okay, there's some infection which is causing damage to the wall of the blood vessel. So this is an analogous process to infective endocarditis in a sense that there is infection, but where is the infection present? It is not in the heart valves. The infection is not in the heart valves. It's not a damage to the endocardium. Where is the damage present? Let me say person is having an arteriovenous fistula which has become infected. Or instead of arteriovenous fistula, let me say person is having a arterial fistula or arterial shunt. Like, let me give an example of a condition where you have a arterial shunt. In pediatrics, you read about congenital rubella syndrome, babies developing patent ductus arteriosus. Then in PDA, the communication is between aorta and the pulmonary artery. That connection between the ductus arteriosus is what I'm talking about, the connection between the aorta and the pulmonary artery. If that connection gets infected, the term used is, I mean, if there's an infection of ductus arteriosus, the term used is infective endarteritis, or I mean, any person who's having any intracardiac devices. I mean, I spoke about multiple intracardiac devices. I'll just mention the names once again. Person could be having a CRT in place, or an implantable cardioverter defibrillator, or let me say a pacemaker in place. So again, there could be local infection occurring with respect to those intracardiac devices and the catheters which are tunneled. And as a result of it, I mean, the disease process would be referred as infective endarteritis. The main message is the term, it's not endocarditis. I mean, English itself is self-explanatory in this case. It's blood vessels getting involved involved, or even with respect to the insertion of intracardiac devices, because after all, like a pacemaker would be put in the left side of the chest and the catheter would be threaded subcutaneously into the chamber of the heart. So the infection will go via the leads or the wires which are going to be connecting the battery and the hardware of the pacemaker or a implantable cardioverter defibrillator to the heart surface per se. So therefore, I mean, the meaning of the term infective endocarditis is what I've explained to you at the moment. Another miscellaneous statement that I would like to say is that prostatic valve endocarditis. I did speak about the fact that in prostatic valve endocarditis, the organisms will change first 2 months, 2 to 12 months, and then after 12 months. I mean, for the first initial two datas, it was cons. After 12 months, it was streptococcus viridans. Here, all I'm saying is that the risk of prostatic valve endocarditis is max in the first year. I mean, as compared to infection developing after 1 year, most of the time, if we compare cases in the first year and cases after 1 year, cases in the first year are relatively more common. And then what you can also ask you is that with respect to two types of artificial heart valves that we deploy, one we have is metallic valves, and second we have is bioprosthetic valves. As if you go by the English word, once again, bio means biocompatible, and therefore it's more akin to human tissue as compared to a metallic valve. So metallic valve has lesser incidence. People who are having a metallic valve in place, they tend to have a lesser incidence or development of infective endocarditis as compared to patient who's having a prosthetic valve in place. As far as TAVR is concerned, I've already explained to you that we do not remove the old aortic valve. The artificial heart valve is deployed over and above the calcified valve. Now, in earlier times, we were not having this facility, and interventional cardiology was not so developed. Let me say, if I go back 20 years when I was doing my post-graduation, we did not have, a cath lab was like something, a very alien concept, mainly based in America, never heard in India. And then it was more of, I would say, open heart surgery, where the old aortic valve has to CTVS was the branch then. And a very, very dynamic branch at that point of time. Now interventional cardiologists are replacing it. So the point is that in earlier times, we were using open heart surgery and we were removing the old heart valve, deploying a new one. Chances of stroke was also very, very high. So he asked whether, if you compare the risk of post TAVR prostatic valve endocarditis versus that of open heart surgery, then they found in clinical studies that the risk of interventional cardiology based procedure, where the old valve is not removed and the new valve is deployed over the damaged valve, versus a proper surgically implanted bioprosthetic device, then the risk is turning out to be equal. I repeat the fact once again, that overall in bioprosthetic devices, risk is more. Listen to the data carefully. When I'm comparing bioprosthetic versus metallic valve, bioprosthetic valve has a higher incidence as compared to metallic valve. But when I'm talking about a cath lab procedure versus open heart surgery, that is a surgically implanted, this was a surgically deployed or a surgically implanted bioprosthetic device, then the risk was found to be equal. So because these could be statements in MCQs and you could say all are correct with respect to the chances of development of infective endocarditis, you need to get these statements correct. I repeat the fact once again, overall bioprosthetic devices higher chances as compared to metallic valves. But when it comes to a TAVR PE versus open heart surgery, in both of them we are trying to fix a calcified aortic stenosis. I mean, I think all of you are aware of the guy Terminator, no? Arnold Schwarzenegger. He was a bodybuilder, and at 70 years of age, this particular chap, former bodybuilder and governor of a big province in America, and obviously famous for the movie Terminator, he developed valvular aortic stenosis, and in America he underwent this procedure, TAVR. So it was all over the news. I think it is 2018-19 that Arnold Schwarzenegger, who was supposed to be a very fit individual, developing a calcified. So calcification of the valve, aortic valve, can develop in patients after or around 70 to 80 years of age. And in case they are getting this valve deployed in a cath lab, then intraoperative contamination or postoperatively, either of the two, the chances of infective endocarditis will be very much there. Plus, I've already explained to you that if a person is having a cardiovascular implanted electronic device, even after this, there would be a risk of development of infective endocarditis. And on a comparison basis, the risk with respect to pacemaker versus ICD, then the risk will be higher as compared to in a implantable cardioverter defibrillator with respect to pacemaker. I'll mention only those statements once again where the values are turning out to be higher. I'll repeat the facts once again. Incidence of infective endocarditis with mitral regurgitation is higher as compared to that of valvular aortic stenosis. Similarly, if I move on to the subsequent slide, I have told that the incidence or development of infective endocarditis with a bioprosthetic valve will be higher as compared to a metallic valve. And then I've said with respect to a tachyarrhythmia managing device versus a bradyarrhythmia managing device, the risk is more with a tachyarrhythmia managing device, and this is just epidemiological information that could be forming at least one choice in an MCQ with respect to the medicine perspective of infective endocarditis. One option could be bacteriological information, the organism specific approach. One option could be the data that I'm telling you, the incidence being higher in which situations. One option could be with respect to treatment, and one could be the modified Dukes criteria. So modified Dukes criteria, I know that you are good at it, major criteria, minor criteria. We will discuss them subsequently, but those are much more, I think, easily remembered by students. So that's why I'm not focusing at the moment over the modified Dukes criteria, but I'm talking more about these processes or chances of higher incidence of infective endocarditis with which situations is what I've highlighted at the moment. Another aspect that can be asked in the exam is with respect to culture negative endocarditis. Now, why would that be possible, or how would that be possible? Then one of the reasons for development of culture negative endocarditis could be simply prior antibiotic exposure. I mean, by the time the patient comes to our hospital, he's been to so many private practitioners that he's already taken oral and maybe parenteral antibiotics as well, because of which the blood culture is bound to turn negative. But that may not always be the case. Most of the time what we are getting nowadays is that if a person is having culture negative endocarditis, obviously first thing to be ruled out is previous antibiotic exposure. But suppose he has not taken antibiotics and still the culture is turning out to be negative, then means that the organisms that are going to be present here are relatively more nasty in a sense that not that they will cause more destruction than Staph aureus. When I mean nasty, I mean here that they are present, but they are not detected by a routine culture media. Fastidious organisms are more difficult to grow on the standard culture media. Which are these fastidious organisms? There's a huge list of it. I mean, Streptococcus, some of the species cannot be growing. I mean, the traditional ones will obviously, Streptococcus viridans will grow, but then some of the Streptococcus subtypes may not be growing on a culture media. And then a couple of names which I think you should be remembering from the exam perspective. One of them would be Granulicatella species. Another one to be remembered is A. biotropia species. I repeat the names once again, a bit of tongue twisting names, so I thought I'll just invest a few seconds into this. Culture negative endocarditis can be seen with some species of Streptococcus, then is Granulicatella, then is A. biotropia. Then is the hot favorite of our examiners, even in the combined medical services, UPSC, they ask about HASEC group of organisms. For HASEC group of organisms, H would be Haemophilus species, pretty straightforward, so I will not write it. C is Cardiobacterium, very straightforward, taught in microbiology, so I'm not writing it. E is Echinella, K is Kingella, so no big deal. Please comment without looking at the notes what would be A for. H is Haemophilus, Cardiobacterium hominis, E is Echinella, K is Kingella. I'm looking for your answers for A without looking at the notes. I know you have printed notes at your disposal. Yes, guys. A here, when I take a live class, why I ask that is because, usually when I take a live class, I get answers like Actinobacillus and Acinetobacter. Whereas if you go through the data in Harrison, he's using a much more broader term, that is Aggregatibacter species. Repeat again, for HASEC group of organisms, it is, they've gone to the depth of asking you treatment for HASEC group of organisms, which are more difficult to cultivate. So I'll talk about the treatment part also. H is Haemophilus species, is Aggregatibacter species, Cardiobacterium, Echinella, Kingella. The next one to be remembered, and we'll talk about the treatment of this also, is Bartonella. Then is Whipple's disease, the organism that causes Whipple's disease. This is gonna be a bug hiding in the macrophages of the intestine. It's PAS positive bacteria, intracellular bacteria, which cause a malabsorption syndrome that's called as Tropherma whippleri. So Tropherma whippleri can be having CNS manifestations. I'll not go into Whipple's disease at the moment, but can have CNS implications, can be having cardiovascular implications, and could also be incriminated in causing infective endocarditis. Other species are like Corneobacterium propionum, the one that causes acne, right? Propionibacterium acnes has also been demonstrated or responsible. Then the next one, which Harrison has mentioned, is a Mycobacterium species. This would be Mycobacterium chimera. And why it's important is because this was responsible for a couple of outbreaks of prosthetic endocarditis in certain hospitals. So I'll just mention in a few seconds from now, I mean, when, in which scenario these outbreaks of prosthetic valve endocarditis were basically reported. And they said that these outbreaks were reported in those patients who had actually been exposed to cardiopulmonary bypass machines. I'm not saying that every time a person will be exposed to a cardiopulmonary bypass machine, he can end up with this infection. But in case, I mean, the standard sterilization techniques which are used with respect to cardiopulmonary bypass machines are not used, then there have been a couple of outbreaks. I'll just mention that separately. And this is given in Harrison, so that's why it's being taught to you. The question said that a couple of outbreaks of prosthetic valve endocarditis were later found to be attributed to imperfect sterilization techniques being followed in the hospital with respect to the cardiopulmonary bypass machines that were being used in CTVS. So one you need to remember the fastidious organisms responsible for culture negative endocarditis. And second would be a even much more, I would say, demanding aspect, that how would you be finding that these organisms are present? I mean, it's like finding a needle in a haystack. If the culture is negative, how do you determine that these organisms are present? Any technique available by which, any panels available by which you can pick up the fastidious organisms? Well, your answer would be a very fancy name. Very, Americans love guns, so that's why maybe they came up with this name, that is short metagenomics. I'll explain what that means, but if you just focus on the word short, like fancy, Americans have a fancy for guns, you very well know. So short metagenetics basically would mean that this would be a next generation sequencing. Now, what this next generation sequencing means is that we are going to try and find out the DNA. We are going to try and find out the DNA of the bacteria or the organism in the serum of the patient. I mean, basically what next generation sequencing is doing is that it is doing sequencing of the DNA. It is trying to do sequencing of the DNA of the pathogens which would be present in the serum of the person. So there's a proper panel for it, and this would be a much more accurate way to pick up these bugs, the nasty ones, in a sense that they are there but we cannot see them. With the conventional culture media would fail to identify these organisms. And here I would also like to mention that how or what would be the portals of entry. I mean, what I'm saying next is, again, I would say a repetition from microbiology, but worth the effort. That how is it that Staph aureus is getting access into the body, or how is it that streptococcus is getting access into the body? So, I mean, human body is in symbiotic relationship with bacteria. We all know that. So with respect to the portals of entry, it could be oral cavity. Why that's important is because towards the end, we'll talk about, I mean, a person having a heart disease is undergoing a dental procedure. Then in those circumstances, we'll always give antibiotics. Amoxicillin or ampicillin would be given at least 1 hour before the procedure to reduce the incidence of cardiovascular complications or infection that would be occurring. So especially with respect to oral cavity, or with respect to the skin, or with respect to the upper respiratory tract, 2 organisms would be very much prevalent. That is, Streptococcus is one of them, and second would be Staphylococcus aureus. I mean, these are going to enter from this area, and therefore we will discuss subsequently what is the in which situations, what cardiac conditions should be present where prophylactic antibiotics should be given before a dental procedure. Then which organism would be with respect to, or would be present with respect to the GI tract, and then would get access internally. And I mean, most of the time, the organism that I'm going to talk about, the incidence of this has been found to be higher in people who are either having a tumor in the GI tract or are having polyps in the GI tract. I mean, these patients tend to have a higher incidence or development of infective endocarditis with the following organism. No, it is not Streptococcus viridans. It's not Streptococcus viridans that I'm talking about at the moment. From the GI tract, I mean, especially with respect to, if a person is undergoing a colonoscopy, though traditionally, currently, if a person is undergoing a colonoscopy or a genitourinary procedure, there is no need for antibiotic prophylaxis in people who are already having a heart damage. It's only for dental procedures that's recommended. But still, with respect to GI, you need to know the organism that comes in. and that would be Streptococcus gallolyticus. Then I mentioned about genitourinary, so I'm just writing GU, and the organism that would come in here would be Enterococcus. So these are the portals of entry, oral cavity, skin, upper respiratory tract, GI, genitourinary. And the learning for us is that suppose a person is having a genitourinary infection and is having heart disease, then this genitourinary infection should be treated aggressively. All genitourinary infections have to be treated, obviously. But here I will be more aggressive in somebody who's already having a cardiac lesion, because a chap who's having a genitourinary infection, if he undergoes in the setting of an infection, if he undergoes a genitourinary procedure, the infection gets into the bloodstream and goes into the heart. That's why Enterococcus was coming in so many times in the discussion. Similarly, if a person is having, with respect to Streptococcus or Staph aureus oral cavity, a person who's having a cardiac valvular lesion already present and maybe he has already had an episode of infective endocarditis, I would tell him to use ultra soft brush. I would tell him to not injure his gums. I would tell him to take good care of his dental hygiene. And if, in spite of that, if he's having dental caries and tomorrow he needs to go for a root canal treatment, or there's a dental abscess and he has to go for a dental extraction, these patients would be put on antibiotic prophylaxis to prevent further damage to the heart of these patients. And coming to the pathogenesis of the disease, you need two things for development of infective endocarditis. One is obviously the bacteria, and second would be endothelial injury. Now, the reason for development of this endothelial injury would be a high velocity jet of blood. Let me say patient is having valvular mitral regurgitation. So the jet of blood that would be leaking from the left ventricle to the left atria will cause local damage. Or instead of this, I can say, let's say a patient is having a ventricular septal defect or a patent ductus arteriosus. So therefore I'm writing low pressure side of a congenital heart disease. What I mean by low pressure side of a congenital heart disease would mean, like in VST, the blood is going from left ventricle to right ventricle. So right ventricle would be the low pressure side. So in either of these two scenarios, that is whether it's going to be the left atria or whether it's going to be the right ventricle of the patient, where the jet of blood will land in VST versus jet of blood for mitral regurgitation, in that particular area, there will be a formation of a platelet and a fibrin based deposit, which is called as non-bacterial thrombotic endocarditis. You see, I'll repeat the fact once again. I said that the combination of endothelial injury and bacteria is responsible for it, but the first prerequisite is endothelial injury. Once that endothelial injury occurs, there will be a platelet fibrin thrombus that would be developing either in the left atria in a case of mitral regurgitation, or developing in the right ventricle in patient of a ventricular septal defect. And this platelet fibrin thrombus is called as NBTE, that is non-bacterial thrombotic endocarditis. Though you will read this term non-bacterial thrombotic endocarditis even subsequently when I talk about, I would say, non-infectious conditions as well. The non-infectious conditions where you could be having non-bacterial thrombotic endocarditis could be even a hypercoagulable state like antiphospholipid antibody syndrome, or there's a blood cancer, acute promyelocytic leukemia, that could be associated with development of non-bacterial thrombotic endocarditis. So the point is, malignancy can cause non-bacterial thrombotic endocarditis. We could be having antiphospholipid antibody syndrome causing non-bacterial thrombotic endocarditis. But even in the pathogenesis of infective endocarditis, initially what develops in the heart is a lesion that is devoid of infection. This area or the lesion in the heart that develops is a platelet fibrin thrombus, which is called as non-bacterial thrombotic endocarditis. And then over this damaged area, over this thrombus, the bacteria can seed. These bacteria which can seed, not all bacteria, but some of them which will seed will be the ones which would be having MS cram. What you mean by the word MS cram is, as the name, the English full form is mentioned there, microbial surface component that recognizes the addition matrix molecules. What I'm trying to explain is that on the surface of this bacteria, there would be some recognizing molecules present which will help these bacteria attach to this particular area of non-bacterial thrombotic endocarditis. So initially we have endothelial injury and NBTE, and then subsequently we have couple of bacteria which have MS crams, and it looks like some fancy missile name from United States again, MS cram. The full form is microbiological surface components that are able to recognize the adhesion matrix or those molecules which are expressed on the surface of this platelet fibrin thrombus, and therefore the infection process then tends to proliferate, and then these vegetations will start growing in size. And when the valve will open and close due to the dynamic nature of the valve movement, there is a possibility that these enlarging vegetations over time can break from here, and a big chunk of it or a complete vegetation can embolize into distal circulation, and then all hell will break loose because you are having bacteria being pumped into systemic circulation. This is what I'm saying. Let me just show you on the subsequent slide. I said initially on the surface of the valve or with respect to the surface of the heart valve, we were having structural damage. And then you are having bacteria which are seeding onto this area. The vegetations, which I have currently shown in white, are increasing in size. These vegetations which can develop on the heart. This time I'm not showing mitral regurgitation. This time I'm showing the aortic valve. This is left ventricle, this is aorta, and we're having vegetations developing on the heart valves. Now these vegetations can break off from here and they can go into the distal circulation. So the problem is embolization of these vegetations. Due to embolization, there can be a couple of aspects that can be occurring. What are the complications that can be seen due to embolization of vegetations? Let us see. The embolization of vegetations can one result in bacteremia. This bacteremia will explain the high-grade fever with chills and rigors, and it's no big deal that this infection can then seed organs you will hear me saying splenomegaly, which is due to splenic abscess developing in these patients. Kidney abscess, any organ abscess can develop in these patients because of the bacteria which are going to be kicked into the systemic circulation. Over and above these, the embolization of the vegetations can also cut off the blood supply to various organs or parts of organs, like multiple vegetations went into brain circulation. So you could be having multiple infarcts, or they went into renal circulation, kidney circulation, or spleen circulation. So person could be having flank pain, organ pain, as I'll be describing. Like you read in sickle cell anemia, sickling episodes trigger abdominal pain. I am today telling you infective endocarditis can trigger abdominal pain. It could be pain in the left hypochondrium. It could be pain in the flank area. That could be due to some small branches of the renal artery getting occluded or splenic artery getting occluded. And in fact, there will be septic emboli. Or I can say another thing. Suppose person is a IV drug user / people who inject drugs. There's a right-sided endocarditis. So the infection of the vegetations in the tricuspid valve could break off from there and go into lung circulation and could cause pulmonary septic infarcts. So you could be having seeding of organs, splenomegaly, you could be having infarction of organs developing. And apart from this, we also read about in these patients in the pathogenesis component, tissue injury that occurs due to circulating immune complexes. Because during the course of this discussion, I'm going to talk about glomerulonephritis. I'm going to talk about hematuria, which could be occurring in these patients. So tissue injury that occurs due to circulating immune complexes, and that's why we read about glomerulonephritis. This guy had a streptococcal infection in his heart, and then subsequently there are circulating immune complexes that could explain the glomerulonephritis that occurs in these patients. So it's a potentially disaster situation as of now, and I'll now increase the disaster. So please give me undivided attention on the slide at the moment. I'm just zooming it in, and the person was not detected. He had fever, which was with chills and rigors. We thought it is COVID. We worked him up for influenza, malaria, typhoid, dengue, all the routine infections that we think of being present in a patient, typhoid, even workup for tuberculosis was done. This guy was extensively investigated for all the routine common infections. I repeat again, COVID-19, influenza A, malaria, typhoid, dengue, then tuberculosis, all the routine common infections seen in India, they have been ruled out. And the person is having infection, he's having a structural heart disease. He might be a rheumatic heart disease patient in India, or alcoholic with dilated cardiomyopathy. Some predisposition will be there, or it could be simply a guy with no structural damage in the heart initially, but he's having a predisposition like IV drug usage. So in these patients, the infection will increase in magnitude. What I'm trying to show at the moment is a valve abscess. The pus is spreading in the tissue of the valve, and God forbid if it happens, then antibiotics will stop working because antibiotics never penetrate into abscess area. You see, a valve will not have a blood supply of its own. Valve takes nutrition from the whatever blood is present in the heart, in the left ventricle, sufficient amount of oxygen is there. So this particular area, antibiotics are not gonna reach, and the infection is gonna go deeper, deeper, deeper. Literally the bacteria is eating away into the tissue, the valve, and there is a possibility one fine day that there could be a perforation. Look at the horrible situation I created. There could be a perforation developing in the valve leaflet, and because of this perforation developing in the valve leaflet, now the aortic blood will get access into the wall of the left ventricle. I did not say that chordae tendineae of the heart valve were damaged. I had never said chordae tendineae. I mean, we don't have chordae tendineae with respect to the aortic valve anyway. For mitral valve, the chordae tendineae concept is very much there. But here, what I'm talking about is a perforation in the valve leaflet. There's a structural damage which is occurring in the heart, and this is the reason why during the course of Modifax Dukes criteria, that's our objective. You will hear me say that if a person is having a development of new onset valvular lesion, I mean, this valvular lesion was not, I'm not saying that there is worsening of a pre-existing lesion. I'm not saying that there is a worsening of a pre-existing murmur. There is a new onset murmur. There is a creation of a new onset valvular lesion, and why this new onset valvular lesion has developed in this person is because of the perforation that has occurred in the valve leaflet thanks to the progression of infection, because the disease process remained undetected. The suspicion of infective endocarditis was not kept in this patient. Had I kept a high index of suspicion in a person with a predisposition, I would have subjected this guy to a transthoracic echocardiography or a transesophageal echocardiography. I would have drawn a blood culture in a person. Though I'll talk about techniques even beyond a echocardiography, which can help us pick this up even early, though not available in India half the time. But the point is, let me say, three-dimensional transesophageal echocardiography is superior as compared to a transthoracic echocardiography to pick up a valve abscess or a paravalvular fistula that can develop in these patients. In fact, guys, the infection in the heart of these patients can be so deep-seated that it can damage conduction system of the heart. So imagine if conduction system of the heart, bundle of is damaged, heart blocks will develop. Second degree, third degree heart blocks can be present in patients of infective endocarditis if the diagnosis is not made. If the infection comes in the septum of the heart, it's a bad prognosis, because in the septum you have bundle of hairs and then you have two fascicles of bundle of hairs. So if the bundle of hairs gets damaged, the bad news is development of heart blocks in these patients. So from the pathogenesis perspective, guys, what I've tried to say is you need two things here. You need, clapping requires two hands. So here, endothelial injury plus MS cramps, the combination of the two is going to be a recipe for development or damage. Over and above this, I said additional fact, which I did not write earlier, but I'm writing at the moment also, that non-bacterial thrombotic endocarditis, NBTE, can occur in hypercoagulable states. I mean, it's not a necessity that all the time NBTE will get converted into an infective endocarditis subsequently, and the person, I mean, not always organism with MS cramp present on them may be present, or even if they are present, person took antibiotics and therefore it's goodbye to possibility of infective endocarditis. So you can be having non-bacterial thrombotic endocarditis even in a hypercoagulable state, and if that happens, then the term that is used to describe it will be different from the term infective endocarditis, obviously because there is no infection at the moment. This is due to hypercoagulable state, and therefore the term used to describe this is also taught in pathology, that is meranteric endocarditis. Well, what would be causing it? Then your first answer would be, though I've said it verbally, I'll just say that once again, this could be associated with a malignancy. And the malignancy I'm talking about is acute promyelocytic leukemia. That's the M3 variety of acute myeloid leukemia. Though couple of even, I would say, ovarian malignancies are related to development of this meranteric endocarditis. Another cause for this could be anti-phospholipid antibody syndrome. So the message is that alone endothelial injury is not responsible for infective endocarditis. You need a combination of endothelial injury plus organisms expressing MS cramps, and the two together contribute to infective endocarditis component. In case you don't have it, then the term used is meranteric, I mean only endothelial injury, meranteric endocarditis, which could be explained by malignancy or could be explained by anti-phospholipid antibody syndrome as well. So the cardiac manifestations that could be developing in this patient could be in the form of a valve perforation that I've already explained to you and can be visualized on echocardiography. Instead of perforation, he could mention the word paravalvular abscess. Or instead of saying paravalvular abscess, he might say the word ring abscess, because if he says paravalvular, it will be easier for you. So paravalvular abscess ki jagah pe he might say the word ring abscess as well. Then heart blocks could be occurring, bradyarrhythmias. They are complications that might result in even syncopal episodes and a possible death in these patients. If there is damage to the heart valves, especially mitral regurgitation lesion with infection, then the pulmonary edema component can be severe enough to cause a ADCHF or acute decompensated congestive heart failure in a patient. The infection can burrow deeper and can cause communication between the various chambers of the heart. So intracardiac fistula, you see the infection is causing local damage to the extent that there could be communications developing between the various chambers of the heart, which is why I use the word intracardiac fistulas developing in these patients. And then with respect to especially aortic valve vegetations, the risk is that these vegetations, which are very small, could enter into the coronary ostia. From the coronary ostia, they navigate into the coronary circulation and can even cause a myocardial infarction in these patients. Yes, guys, infective endocarditis can contribute to myocardial infarction. How? Because of the coronary embolism of those vegetations. I mean, those ultra small vegetations that are going to break off due to the shearing stress of the opening and the closure of the heart valves could result in these disastrous situations occurring in these patients. So that's why, I mean, we read about new onset valvular lesion. I mean, new onset valvular lesion heralds the damage is pretty substantial. And what I've told you is a step above this, that if we are not able to recognize this, then there's a high probability that this person will die. And though these extreme kind of manifestations are usually rare nowadays, I mean, acute factor in a scenario of easy availability of antibiotics and a scenario of evidence-based medicine where we use echocardiography, ECG, ultrasound, PET scan, even in cardiology to pick up infective processes, the chances of development of these extreme complications would be relatively lesser, and therefore it is all the way more important that we also focus on the non-cardiac manifestations that would be developing in these patients. Now, as far as the non-cardiac manifestations are concerned, one, I'll just use a general term to describe, and this would be mentioned even with respect to when we are going to talk about the modified Dukes criteria. I can just use a broader term at the moment: peripheral manifestations that occur in patients of infective endocarditis. One of the peripheral manifestations that could be occurring is like a splenomegaly. Now, okay, let me first mention the classical terminology, then I'll come to splenomegaly, because splenomegaly I've said already, you know, the infection from the heart will go to spleen. So splenomegaly goes to kidney, renal abscess, then there could be splenic infarct, renal abscess, that I've already told you. So that's why I wrote it and I decided to erase it just to tell you about those points which I've not spoken about. Like, let me say, I speak about erythematous macules, which are found on the palms and the soles of the patient. You read about this even in your, final year MBBS, that is Janeway lesions. So these can be described as a non-cardiac manifestations, again because of the embolization of vegetations into the systemic circulation. Similarly, person could be having hemorrhages below the nails. That would be written as subungual hemorrhages. What I'm trying to jot down before you are a couple of peripheral manifestations. The next one that I've written would be seen on a fundus examination of these patients, that is rot spots. Though I want to tell you that rot spots can also be seen in patients with blood cancer. They can be seen even in lymphomas, and rot spots can be encountered even in anemia. I mean, the first time when we read about rot spots, no, the impression is, okay, man, this is very specific for infective endocarditis. It is not. It is not. Rot spots can be seen even in leukemia, lymphoma, anemia. In fact, this is itself one of the questions of previous years NEET PG questions had. Rot spots are found in, and in the options, infective endocarditis was not in the options. And those who had not listened to this, they were fumbling for answers, sir, no infective endocarditis. The answer in that question was leukemia. I told you even lymphoma and even anemia, which explains to you another fact. Rot spots is a minor criteria. Why a minor criteria? Because a rot spot can be seen in so many conditions. Apart from infective endocarditis, I cannot call it a major diagnostic criteria. Another peripheral manifestation is ossular nodes. The site where you will check for the ossular nodes in the patients would be the tips of the fingers. So a couple of peripheral manifestations are what I've tried to explain here. And over and above these, the vegetations can also contribute to blockage of the digital blood vessels. And if you occlude the digital circulation, there can even be a possibility of gangrene developing in these patients. So these would be a couple of peripheral, which is obviously non-cardiac manifestations developing in these patients. When it comes to Janeway lesions, this would be a non-suppurative manifestation. It would be a erythematous reddish macule seen in the palms and the soles of the patient. On the other hand, when it comes to osseous nodes, these would be like PEA, P-shaped nodule, suppurative manifestation seen in the tips of the fingers of these patients. Over and above this, you could be having stroke, which is an unfortunate complication, cardiovascular emboli. You could be having regional pain. It could be abdominal pain or any area pain developing in these patients, mainly because of the infarction of any, like in sickle cell anemia, no, you read about splenic infarction, or you read about multiple organ infarction occurring in sickle cell anemia due to RBCs being sticky and they occlude blood vessels. Here it is the vegetations which are causing occlusion of vegetations. Or instead of saying regional pain infarction, I can say organ dysfunction as well. Most of the time, the organs that can be involved are like the kidney or the spleen of the patient. And therefore, I also want to say, though I've said this splenomegaly multiple times, guys, splenomegaly is not again a diagnostic criteria for infective endocarditis. Why? Because splenomegaly is so common that it can be seen in malaria, kala-azar, blood cancers, leukemias, lymphomas. So, I mean, we cannot take that even in the minor diagnostic criteria. Splenomegaly is a splenic infarction. If you read about splenomegaly in a question on infective endocarditis, do not incorporate that as a part of the diagnostic criteria, not even a minor diagnostic criteria. For Roth spots now, at least I was saying consider that as a minor diagnostic criteria. For splenomegaly, I'm saying don't even consider that as a minor because it's a complication. It's a gross complication that is seen in patients which are usually undetected. Over and above this, the infection go in the brain and you could be having multifocal brain abscess. Normally, you read a solitary brain abscess. I said multifocal, multiple septic emboli going out of the heart, contributing to multiple septic emboli, contributing to multifocal brain abscesses or development of meningitis. And if we are going to be having infection going out of the heart towards the brain, it could also cause infection of the wall of the blood vessels supplying the brain, and therefore you could be having a mycotic aneurysm. And because there is a weakening, there's a structural damage to the wall of the heart, it can pop off anytime, and you could even be having intracranial hemorrhage in these patients. So it's like lots of peripheral, lots of nasty things coming up here, like stroke coming up, brain hemorrhage possibly occurring in these patients, kidney infarction, splenic infarction, and all of these that I've said are manifestations. They are most of the time complications that are seen. And in this particular list, I mean, which of these would you be incorporating in the minor criteria? Though I'll be speaking about these even on my subsequent slide, but the ones which I wanted to take into consideration at the moment are at least 3 of them, which would be included in minor criteria. Remaining that I've written can be seen in so many other conditions. The list is so exhaustive for subungual hemorrhages. List is so exhaustive for meningitis that we cannot take them. In obviously mycotic aneurysm again will be something very peculiar to infective endocarditis. I mean, that's the root cause of it. But when I talk about modifies Duke's criteria, you will notice that all the things that I've written on the slide, all of them will not be incorporated, only some of them. The reason is what I'll say once again. I mean, when I say cardiovascular emboli, when I say meningitis, there could be so many vast array of reasons responsible for it that they would not add to the diagnostic criteria. So splenomegaly should not be answered as a diagnostic criteria, and was a question in the previous years. I mean, he did talk about the ones that are marked, but splenomegaly is a complication. Splenic infarction is a complication seen with this condition. And next up is the most important part of this discussion, that's modified Duke's criteria, where we'll talk about the algorithm first. Why? Because it operates a little different from the modified Jones criteria. You will take into consideration, I'll explain the major and the minor ones to you, but first I would like to highlight that you will take into 2 major criteria, but there's no minor in the first point that I've written. When do you take into consideration the minor criteria? Here is if a person is having only 1 major and 3 minor criteria. So you can see that the way these criteria operate will be different from the way the criteria would be operating. In fact, he can deliberately give you a situation where none of the major criteria would be present, and you would be basing your diagnosis in a 2 or 3 liner question on the basis of the multiple minor criteria that could have been described in the question. So one, you get the algorithm right. Second, we'll focus on one of the investigation which is done for this patient, which is blood culture. If he says that while you are suspecting this patient, what is first investigation to be done in any case where you are having a high index of suspicion, we'll do a echocardiography. But one of the paramount investigation that will decide the treatment of this patient is blood culture, because I need to find out which bacteria is causing it, because each bacteria would be having a different sensitivity, a different MIC would be valid for a different bacteria, which a whole gamut of it, which I've spoken about. So with respect to the blood culture, what we usually do is that we take 3 sets of 2 bottle culture each. What I mean by 3 sets of 2 bottle culture each is, like, I'll just try to give a diagrammatic representation. This would be 2 bottles of 10 ml 10 ml each. Then this is set number 2 and this is set number 3, and I'm going to send it to the lab so that we could culture the organisms from 3 sets of 2 culture bottles each. Why I'm particular about this is because of the fact that in the MCQs he'll try to upset your rhythm here by writing terms like 2 sets of 3 bottles each. The correct data is it is 3 sets, like set 1 2 bottles, set 2 that's 2 bottles, and then set 3 also is 2 bottles. Each of them 10 ml of blood would be taken, and the site where you would be taking would be different every time. Like for example, if I took a blood sample in this patient for set number 1 from the left cubital fossa, then the second sample should be taken from from the contralateral cubital fossa. I mean, why I'm trying to do that is to, one, reduce the chances of site contamination, repeated trauma at the same site, plus site contamination is also to be minimized. So from different venipuncture sites, why different venipuncture sites is because of, one, I said I want to minimize the trauma at the same site contamination. If one side is contaminated, problems would occur, and more importantly in fact, I want to demonstrate dissemination of bacteria from the heart. I mean, wherever I'm taking the sample from, I am being able to generate presence of bacteria in the sample. And out of these 3 sets, at least how many sets should be positive? So at least 2 sets should be positive, and both sets should be positive with the same organism. Like suppose set 1 is Staph aureus and set 2 is also Staph aureus stool. But if set 1 is Staph aureus and set 2 is, let me say, set 2 is Staph epidermis or cons, and set 3 is negative for any bacteria, then if then I cannot incorporate that as a major diagnostic criteria. I repeat the fact once again. I said 3 sets of 2 bottles each, and out of these 3 sets, at least how many sets should be positive for it to be incorporated in major criteria? Then I'll say at least 2. Suppose it is only 1, then I'll incorporate that in a minor diagnostic criteria, and we are supposed to take sample from different venipuncture sites over a span of 1 to 2 hours. In the table, he has written 1 hour in Harrison, but in the literature he has written a range of 1 to 2 hours. So I would not like to place any controversy with respect to should you answer 1 hour or should you answer 2 hours. It is that it is a range between 1 to 2 hours depending on convenience. Like suppose in the morning at 8 a.m. I take a second sample at 9 a.m. the third sample can be taken at 11 a.m. then I can go to my emergency or to my OPD. I mean, the point is, at least why you are doing it at different times, and why are you doing it from different sites? Different time and different sites is just to demonstrate the dissemination, that the heart is the source of pumping these bacteria into systemic circulation. Plus I want to reduce the trauma at the same site. Plus I want to reduce, I mean, if this is local contamination at one side, Staph epidermis cons, I want to minimize those possibilities as well. And once the blood culture will turn out to be positive, then I will be able to know that what is the target that I need to shoot at. Though lots of time we can have culture negative endocarditis with what I explained to you. Culture negative could be due to antibiotics being given, or those organisms that I spoke about, which could be ranging from Topherma bipili to Bartonella. And for that, we have a shotgun metagenomic, that is the next generation sequencing available, where we can find the DNA. I mean, we can do sequencing of the DNA of the bacteria or the organism, whichever it is present in the serum of the patient, and we can know, okay, this was responsible for the damage which was caused to the heart of the patient. But the main points with respect to modified Duke's criteria is, one, the way they operate are slightly different from Jones criteria. For blood culture, you need 3 sets or 2 bottle set each. from different venipuncture sites over a span of 1 to 2 hours. And this would be valid. I mean, when would I do this blood culture? In those patients in whom I suspect a prostatic valve or native valve endocarditis and have not received antibiotics. I'll jot this down also. That's important. I mean, you are gonna do this blood culture only those patients in whom you are suspecting native valve or prostatic valve endocarditis or CIED, where there's a implantable electronic device present, or he's already had a transcatheter aortic valve replacement. In all of these patients, patient not received antibiotics in the previous 2 weeks. I mean, if he has taken IV antibiotics, anyway, the culture will turn out to be steroid. But if he has not received AB, here means antibiotics, in the previous 2 weeks, then these patients, you would be having a high probability of being able to determine what is the organism. Though we have a strategy for culture negative endocarditis also, we can give antibiotics in culture negative endocarditis also, but then it's like shooting in the dark. So blood culture is all the way important in a sense that I need to know where is my target, what is the target's behavior, because every bacteria would be having different sensitivity to different antibiotics. So we do empirical treatment because culture sensitivity report will take 48 hours to come. Once a patient is admitted, you send the blood culture report, the culture report will come after 40 to 72, a sensitivity report will come even later. So initially you will be giving a broad spectrum cover for gram positive and gram negative organisms, but then at the same time, I mean, our objective is to select the right dose of antibiotic for that particular organism for max duration. Most of the time in prostatic valve endocarditis, the treatment would be given for 6 weeks. Parenteral some people have tried oral antibiotics also, but he says ideally for a prostatic valve endocarditis, it's 6 weeks of IV antibiotics to kill each and every single bacteria which is hiding deep inside those inside those sites of those vegetations, where the bacteria will form a biofilm and will cause structural damage to the heart and will cause a high grade spiking fever, and then all hell breaks loose once the vegetations achieve a critical site, and they start breaking off, and there is a fragmentation of these vegetations into the distal circulation when multi-organ involvement develops in these patients. Now, the major criteria, you will take into consideration two things. One is going to be blood culture and second is going to be echocardiography. This is a stark contrast to Jones criteria rheumatic fever, where investigations are minor criteria. I repeat again, in Jones criteria, investigations are a minor criteria, whereas when it comes to infective endocarditis, the major criteria will revolve around investigations. In fact, in modified Dukes criteria, the clinical manifestations like Roth spots will be a minor diagnostic criteria. I gave the logic for that also, but I'll repeat the facts once again. Investigations are to be taken into consideration as major diagnostic criteria. So first and foremost would be positive blood culture. The technical details of positive blood culture I've already told you, but then let's just repeat the main data once again. What he means by the word positive blood culture is that the typical organisms which I've described before you for various situations are to be isolated from two separate blood cultures. We took 3 sets, so at least 2 out of them, if they're positive, I'll say, okay, I'm dealing with a case of infective endocarditis. If these criteria are not strictly adhered to, let me say only one culture bottle is turning out to be positive, then I'll say not even, I took 6 culture bottles, right? And out of them 4 had to turn positive. Let me say only 1 culture bottle or 2 culture bottles are turning out to be positive. I did not say 2 sets. I said only 1 bottle is positive in a set. Then it's not satisfying the major criteria, then I'll take it to be the minor criteria. By typical organisms, I mean organisms like Streptococcus viridans. Where does it get entry from? Then I explained it could be from the oral cavity or it could be from the skin. Then one bacteria I mentioned, Streptococcus, which was coming from the GI tract. I told you that these people who would be having infection with this one, that is Galolyticus, they could be having even a tumor or the polyp. Not all of them, but couple of them might be harboring a polyp in the gut or might be a tumor in the gut also. Then is obviously the standard Staphylococcus aureus, which will come from the skin. And another one would be like Hayesek group of organisms, then even Enterococcus. So these are like those typical organisms where at least 2 positive blood culture sets should be positive. He has asked in the exam in the previous slides, if you're noting it down, making handwritten notes, keep a line in between because I'll add some data here. But he's asked that for which organism for which organism even a single positive blood culture will be sufficient for diagnosis, and your answer will be given as Coxiella burnetii. And the moment I say that, the query that I get from most students is, sir, you did not talk about this organism earlier. I mean, the organism that causes Q fever, suddenly it came up. So all I can offer an explanation is that, especially in rural India, like people might be keeping sheep at home because this organism mainly comes from animals. It's a zoonotic infection. So let me say a patient, his child is having valvular heart disease, 10-year-old child having mitral regurgitation, not stenosis. You don't get a stenosis at 10 years of age. A 10-year-old child having mitral regurgitation due to rheumatic in India, he lives in village in rural India and they keep sheep and cattle at home. So he might get Coxiella infection. So this is a zoonotic infection that's coming in here at the moment, and a single positive blood culture will be sufficient. And then you know from microbiology that Coxiella turning out positive with culture is something very, very rare or very difficult. So he says we can use serological evidence as well, which is that if any infection is present, you are bound to have antibodies present. So he says that immunoglobulin G titer should be present then for Coxiella, and this titer value should be more than 1:800. The data to be remembered is, though he has asked about this only, that when would you take into consideration even a single positive blood culture as a major criteria? Please listen to my words clearly. Here I said isolation of the same organisms from two separate blood cultures. That means two separate sets were turning out to be positive out of the three sets that I took. Then I said, suppose only one bottle is positive or even one set is positive. I'll take that as a minor criteria for these organisms. If it is gonna be, let me say, Staph aureus in one set, then it is minor. But for Coxiella, even a single blood culture bottle positive or antibody titer at this particular value, it would be taken as a major diagnostic criteria. That's one of the important points which is to be remembered. And then you will also read another terminology, and I'll just take a while to explain that. He might use this term, the second one that I'm writing, that is persistently positive blood culture. One I was saying the standard data. Now you take three sets, two bottle each at a gap of 1 to 2 hours, two turning out to be positive. Sometimes he might say persistently positive blood culture. Now let's look at what he means by this persistently positive blood culture. He says that you were able to isolate organisms, the traditional organisms that I discussed, which could be ranging from Staph aureus or Streptococcus viridans, etc. All of those organisms discussed, they were isolated from a blood culture, and this blood culture was drawn 12 hours apart. Normal protocol is that we try to do it in 1 to 2 hour interval. We take three samples, three sets of samples from three different sites. But this is telling you even much more gross phenomenon, that even if the samples were taken 12 hours apart, and even then the culture is turning out to be, it was bound to be positive. No, he is just trying to say here, or this is just an expression of the examiner to demonstrate substantial amount of bacteremia present all through in this person. And I mean, most of the time for persistently positive blood culture, I can say the person will be even much more sicker, because you see there's a continuous shedding of bacteria. There might be intermittent shedding of bacteria. There might be continuous shedding of bacteria. So by this, he just means that there is a more exhaustive damage with the septic process occurring in the heart. There are much more larger number of vegetations present, both from the size perspective and the number perspective, and they're constantly shedding bacteria into the systemic circulation. So any of these descriptions can be given, and most of the time we tend to remember the ones on the top, which are more gross. But the one which was neglected and has been asked in the exam is what I've already sensitized you to, that with especially rural India, where animals might be kept in the home, and a child could, or it could be anywhere in the rural part of the world, maybe in Turkey or anywhere else. I mean, it's not only restricted to India only, but the point is Coxiella is to be taken into consideration as an organism where even a single blood culture positive would be sufficient for diagnosis. The second major criteria that I'll take into consideration would be echocardiography evidence. And this would be that there is structural damage present in the heart, which is ultimately causing an endocardial exposure. And then those bacteria which are having MS cramps on their surface, they come and they adhere and they cause local process or local damage. There are two types of echos that I can be doing. It's a transthoracic echocardiography or a transesophageal echocardiography. On a comparative basis, Transesophageal echocardiography will be having higher chances of picking up lesions in the heart valves as compared to a transthoracic echocardiography. Usually the data is like this. For low risk patients, he says you can try a transthoracic. If you are having a high index of suspicion, IV drug user, fever not going down, routine investigations are negative, he is ending up with a valvular lesion in the heart as well, a new one which was not previously present, run a transesophageal echocardiography which has a higher diagnostic sensitivity than a transthoracic. I mean, obviously, if it's not available, we'll not press for it. We'll try to manage with the transthoracic echocardiography as well. Now on echocardiography, how will you describe it? Most MCQs that will come on this topic might be having incorporation of investigations given. He's going to describe a alcoholic, maybe simultaneously IV drug user or a HIV positive patient. HIV, yes, I would like to tell you, does not change the bacteriological etiology. Suppose it says HIV positive patient with acute bacterial endocarditis, subacute, or CIED, prosthetic valve, native valve, whatever. HIV does not change the bacteria. The HIV does not change the organisms responsible for development of infective endocarditis. So don't get bothered by that HIV positive status, and IV drug usage obviously matters, but not the HIV status. So if it's gonna be an infection in the heart valve, he can either write the word vegetations, or instead of writing vegetations which are relatively bigger, he might write oscillating intracardiac mass. That's just a description to tell you that yes, there are vegetations present. And I would also like to tell you that if the size of the vegetation is less than 2 millimeter, then it might be missed on a transthoracic echocardiography. I told you a limitation, I'm not writing it, I'm just saying it verbally. The limitation of transthoracic echocardiography is vegetation less than 2 millimeter might be missed, which is why transesophageal was told to you to be relatively more accurate. Instead of talking about oscillating intracardiac mass, he might mention the word valve abscess or a paravalvular abscess. Or the next possibility is person is having a bioprosthetic valve and the bacteria has destroyed it. So he might say a new onset partial dehiscence. The terminology that I'm writing at the moment is valid for a bioprosthetic valve which has got secondary. That's a prosthetic valve endocarditis. So you might say partial dehiscence of a prosthetic valve. I mean, any of the echocardiographic finding that I've written here before you, or the simple English word vegetation, will make it relatively easier for you. Or instead of this echocardiography, you might just say that there is evidence of a new valvular regurgitation. In the older editions, he used to say development of a new onset murmur. In the older edition, I used to say new onset murmur. Currently, he says, instead of saying a new onset murmur or worsening of a pre-existing murmur, he says a new onset valvular regurgitation developing in a patient. I mean, it was not present, that perforation in the valve leaflet, why this is occurring. This is because of the perforation that has occurred in the valve leaflet, and this was not present previously. So there are two things to be taken into consideration. One should be positive blood culture, and there should be a positive evidence of endocardial involvement. If these two things are positive, anyway, the two major criteria are satisfied. But sometimes the first criteria may not be satisfied because person has already taken antibiotics. Or it might be the fastidious organisms that I was speaking about before you, like HACEC group of organisms, Haemophilus, Aggregatibacter, Cardiobacterium, Echinella, Kingella. I said it multiple times, so I hope you're remembering it by this time. If person is already taking antibiotics, this goes out of the window. And then in those circumstances, your resort would be echocardiography. But apart from this, you would require 3 minor criteria. So I'm going to now explain on my subsequent slide before you what are the minor modified Duke's criteria which would help you identify your case of infective endocarditis. And the first 3 are pretty simple and straightforward. 1, you must be having in the question mentioned a predisposition to development of infective endocarditis. What I mean by predisposition is that there might be some heart lesion or heart disease present, pre-existing heart disease, like he might just say alcoholic with cardiomyopathy, or there is a patient who's an IV drug user. I mean, if he is himself mentioning regarding IV drug use, then it will make things relatively easier for you. Already told you HIV will not change the bacterial etiologies behind development of infective endocarditis. The person will be sick. Obviously, in acute bacterial, the fever might go up to 40 degrees Celsius and much, much higher. Spiking fever with chills and rigors would be present. And now comes the third one, which I think MCQ wise should be paid attention to. That is vascular phenomenon, which would be described. Let's look at these vascular phenomenon. A couple of them I have already mentioned, but I'll just say them once again. You could be having vegetations from the heart going up to the brain, or sometimes those vegetations might even go into those coronary circulation and might even cause a MI, so major embolic phenomenon. I mean, the emboli went into the left anterior descending artery. Or if a person is having right-sided endocarditis, then the vegetations will migrate into the lung circulation. Imagine bacteria-laden vegetations rushing into lung circulation will cause not only blockage of the branches of the small branches, chota branches of the pulmonary artery, but there is infection going also. So I said the word septic pulmonary infarction. The message is major embolic phenomenon / septic pulmonary infarction is with respect to, I mean, the first point that I've written is for vegetations in the left side of the heart. And the second part that I've written is for vegetations in the right side of the heart. Over and above this, a vascular phenomenon can be that the infection can go into the brain blood vessels, involve them, that is mycotic aneurysm. They can ultimately rupture, resulting in intracranial hemorrhage in a patient. Or we could be having a lesion which is seen, a erythematous macule. This erythematous macule might be present on the palms or on the soles of the patient. These lesions on the palms and the soles are called as Janeway lesions. All of them are referred to as vascular phenomenon. The next one to be taken into consideration would be immunological phenomenon. Most of the time in multiple choice question with respect to the minor criteria, he will try to trouble you with the vascular and the immunological one. And because of this trouble, I would like to sort it by mentioning a mnemonic here by the name of ROG. This alphabet R will be used by you a couple of times, at least two, and then ONG. Let's deploy the mnemonic now. Alphabet R to be remembered first time. This would be for immunological manifestation, that is Roth spots. Next would be positive RA factor. Yes, guys, we read about RA factor with respect to rheumatoid arthritis. After all, RA factor is IgM class of antibody. So RA factor positive could be described as one of the criteria for diagnosis of even infective endocarditis. Alphabet O will be for oscillar nodes. The site where you will check for the oscillar nodes would be in the tips of the fingers, like in the palms and the soles. We were reading about presence of Janeway lesions, erythematous macules. Oscillar nodes would be checked out in the tip of the finger, on the pulp of the finger. And then G would stand for glomerulonephritis, which is oft a neglected part. I mean, we tend to read about classical names like Roth spots, etc., but then glomerulonephritis is worth its effect. Plus, I have also tried to explain to you that why something as important as Roth spot is a minor criteria. That's because of the fact that Roth spots can be seen even in anemia, and even in leukemia, and even in a case of lymphoma, which is why they're minor. And the summary at the moment is, before I write the fifth point, which I'll go on to the subsequent one, is the fact that all those clinical points that I've said, they are to be taken into consideration in the minor criteria. Whereas the major criteria are mainly gonna be to a positive blood culture and evidence of endocardial involvement with the help of an echocardiography in these patients. And now would come the fifth point, which is only for the sake of completion, which is that there should be a microbiological evidence that is a positive blood culture. If you're listening to me carefully, I had told you those 3 sets to be taken, 2 sets to be positive. Here I'm saying that microbiological evidence of a positive blood culture is very much present, but it is not satisfying the major criteria. I mean, if only one set is positive, for example, for Staph aureus, then I take as a minor diagnostic criteria. Positive blood culture, but not satisfying the major criteria is again a microbiological evidence anyway, but is to be taken into consideration. We take into consideration 2 major. If person has taken antibiotic, blood culture will be negative, then only echo will be positive. If vegetations are so small that they are less than 2 millimeter, then even echo will be negative. I'm creating a scenario: antibiotic is taken by patient and vegetations are less than 2 millimeter. Blood culture will be sterile. Echocardiography will be negative. In those circumstances, how would you make a diagnosis? You need 5 minor criteria to be taken into consideration. The algorithm, I'll make you repeat this once again. I know it will sound cliche, but I'm going to make you practice this again because I see people messing it up. It's two major. Two major is gonna be positive blood culture and echo. If you take an antibiotic, blood culture is sterile, no problem. Echo plus three minor criteria. But if both are negative, both blood culture and echocardiography, because vegetation so small is taken antibiotics, no issues. Still have five minor criteria to work out my diagnosis here. I need a high index of suspicion. I should not wait for a person to develop a splenomegaly, a splenic abscess, brain abscess, mycotic aneurysm, intracerebral hemorrhage. All of them are complications. They are complications that are encountered, and most of the questions will say all of the following are features of diagnostic criteria of infective endocarditis except. So that's where you need to take into consideration. If you reach the stage of splenomegaly, you stage the of process of meningitis and a multifocal brain abscess involvement of these patients, it's too late. I mean, most of these patients, especially with acute bacterial endocarditis, though it's become rare now, the chances of mortality in the patient will be dramatically high. Now, before we go into the treatment of these patients, I'll just say a few more miscellaneous points here. The data to be remembered is that if you are having a moderate to high suspicion of infective endocarditis in a patient, IV drug user with fever persisting for, let me say, 7 days, 10 days, 2 weeks, then he says for a moderate to high clinical suspicion, you should be going ahead straight away with a transesophageal. You see, these algorithms are mainly derived from an American perspective, where there is no depth of facilities. Like in our country, I mean, straight away we usually don't do a transesophageal echo because of, I mean, one is the limited resources, and second, we try to use those resources very judiciously. But from an American domain, this is what is to be remembered, that if he says low clinical suspicion of infective endocarditis, what is the imaging modality to be ordered first? The answer is transthoracic echocardiography. Though like in our hospitals we first do a transthoracic and then follow it up with a transesophageal, but this is to be data to be remembered from the American perspective. I've also taught you about short metagenomics, in which next generation sequencing will be done, and this would help us isolate which organism was causing development of culture negative endocarditis. Though lots of time culture negative endocarditis, we might even have to do other investigations. So I'll mention one more investigation which can help us identify the infective endocarditis process, that is multi-slice CT angiography. He says multi-slice CT angiography has a comparable by, let me just write it down here. Multi-slice CT angiography has comparable results in detecting infective endocarditis as compared to transesophageal echo, but both of them are relatively more accurate as compared to transthoracic. I repeat the fact once again. Transesophageal is more accurate than transthoracic. I said that earlier also verbally. Now I jotted down and added another investigation, that is a multi-slice CT angiography, which is a new technique, again may not be available, and all of this is from the American perspective. Plus, if there's going to be an infective process with respect to the heart, another investigation that can be done is a FDG PET CT. I mean, traditionally we tend to reserve this for fever of unknown origin cases. We use it to detect occult malignancy, but now FDG PET is having a very wide gamut of applications, and infective endocarditis is one of them. The minimum message that I want you to remember from the the data that I mentioned at the moment would be like this, that in any patient of suspected infective endocarditis, if he says what is the initial investigation to be done, you will have to select between blood culture and echocardiography. The point is, in the algorithm that is given in the textbook, he's mentioned this, that if you have a high clinical suspicion, you should do a transesophageal. Obviously, you'll do a blood culture also, but only if you're able to see those vegetations, no? That you will be thinking, okay man, there must be a bacteria which is causing these vegetations. Remember I told you, I mean, we need an endocardial surface damage, then those bacteria with MS cramps will come and they'll cause the local process where vegetations will be an amalgamation of fibrin, platelets, bacteria and inflammatory cells. Vegetations are composed of, I'll repeat that again, they're composed of fibrin, platelets, bacteria and a couple of inflammatory cells. So for the entire vegetation process and vegetations to become bigger, and then these vegetations to break off from there and embolize to distal circulation, it takes time, and that is the window that we're looking for, where we'll be able to identify these patients. Next we come to a very interesting part of this discussion, where we'll talk about antibiotics to be used, and the second entry I would rate it as an important one to be remembered. So let's get started with MRSA, documented to cause a native valve endocarditis. This one would be fairly easy and you don't need to be told this. You know this from pharmacology. We'll be using vancomycin slash daptomycin, and the total duration of therapy would be for 6 weeks to kill each and every bacteria which is causing problem here. But when it comes to the same organism contributing to development of prostatic valve endocarditis, we are going to be a little more aggressive. The antibiotics we are going to be using here is vancomycin, then we are going to use gentamicin, and the third one is the main reason why I'm describing this before you, because we'll be using a drug which we traditionally use in treatment of tuberculosis. I am talking about rifampin being used at the moment, and the query would be, why? Then it has been shown because one, this drug is used in tuberculosis because it has a very high kill activity, it has a good volume of distribution, and it specially kills the bacteria. The advantage of using this drug is that it's gonna reach where other antibiotics would not be able to reach. So it kills those bacteria which are embedded in the biofilm. You see, the point is, for antibiotic to reach a particular area, either you need a very good blood supply, and in those areas where there's a biofilm being formed and the antibiotic traditional ones are not able to reach, you need a guy who can actually go into that area and should be having a high volume of distribution. Rifampin does the job here. If it is methicillin sensitive Staph aureus, then the only difference would be everything else would remain the same. But because I'm not having a methicillin resistance, so I can be using nafcillin in this patient, the remaining approach would still remain the same. But this was the main reason why the question came up, that rifampin would be used for management of which of the following. Your answer is MRSA causing a prostatic valve endocarditis. The main logic is high volume of distribution. The antibiotic is able to penetrate and reach those areas where other antibiotics would not be able to reach. If it is enterococcus, then we would like to give cover with ampicillin and gentamicin. And the blood culture report is obviously of paramount importance so that we can choose the best weapon against, and the dosage will also matter of the antibiotic. They don't ask for dosages in the exam, so obviously I'm not going to focus on that. But our objective is to choose the best weapon against a particular bacteria. When it comes to streptococcus, it would be a third generation cephalosporin coming in, that would be ceftriaxone, and along with that we'll be using gentamicin. So I'm trying to give a good cover for gram-negative organisms anyway, and KFT obviously is to be taken care of because the person monitoring of KFT is to be required, because gentamicin would be given for a fairly long duration. The subsequent organisms I'm going to talk about here, the top two you will notice doxycycline would come in. So for Coxiella burnetii, where only one blood culture was sufficient for diagnosis, unlike others where we need at least 2 sets to be positive, and for Bartonella again it is doxycycline. The only small difference would be with Coxiella burnetii, the antibiotic choice would be doxycycline, along with that we'll be using hydroxychloroquine. But if it's gonna be Bartonella, then it's gonna be a combination of doxycycline plus gentamicin. For candida fungal endocarditis developing in a patient, if it is prostatic valve endocarditis, then we should plan an early surgery for the patient because the progression would be very fast. So early surgery is the only way forward. We are going to get rid of the defective valve tissue. Our prostatic valve will have to be deployed, or if there's an original one, then this would have to be replaced by a new one, and fairly large vegetations can develop. For candida, the initial approach would be to use IV amphotericin B, and along with that flucytosine. Traditionally we read about this with the treatment of patients who are having cryptococcal infection, but the same approach, amphotericin B, flucytosine, is being talked. Instead of echinocandis, we're talking about amphotericin B and flucytosine to be used in early surgery in case it's a prostatic valve endocarditis. Towards the end of this discussion, he is going to ask you with respect to high-risk cardiac lesions in which there is a high risk of development of endocarditis. So you need to give a prophylaxis before doing any dental procedure in a patient. Couple of these facts would be very easy to remember, because if a person has already had an episode of endocarditis, even if he says mitral valve prolapse and then says he's already had an infective endocarditis, I would like to give a prophylaxis before doing a dental procedure in a patient. If person is already having a prostatic valve deployed, any person with a prostatic valve in place, prostatic heart valves, we would be giving prophylactic antibiotics. And similarly, if he's having a artificial left ventricle, you see, when I say artificial left ventricle, I mean a battery powered LVAD, that is a left ventricular assist device. This would still be electronic device in the heart, so there is a possibility of this getting involved. Then he would like to talk about especially congenital heart diseases. Like, let me talk about tetralogy fallet. Tetralogy fallet has a subpulmonic stenosis. It has a ejection systolic murmur. And because I'm saying subpulmonic stenosis and a concentric right ventricular hypertrophy, there would be a ejection of a jet of blood from the RV towards the pulmonary artery side. So if a person is having unrepaired congenital heart disease, I mean, not only with respect to, let me say, VST, because that I said earlier also, a person is having VST, then there would be blood moving from the left ventricle to right ventricle. There would be damage to the endocardium of or I can say there would be structural damage to the wall of the right ventricle due to this movement of blood from left to right. And then subsequently, the organisms can come in. So in any case of unrepaired congenital heart disease, there is always a risk, whether it is cyanotic, whether it is acyanotic. And even if, let me say, it's a cyanotic heart disease in which you had put up a BT shunt, like BT shunt or blaloctoxic shunt is a palliative surgery where we connect the subclavian artery to the pulmonary artery so as to establish substantial blood flow to the pulmonary circulation, because in TUF already the blood supply to the lungs is relatively lesser. So a person who's having a congenital heart disease, in spite of the fact that he's had a palliative surgery, there will always be a risk present. Even if he undergoes a repair, let me say person has gone a complete repair of congenital heart disease, but the first 6 months will always be critical. So the message is, if it is unrepaired, there is still a problem, or there is anyway a problem. But even in case of a repaired congenital heart disease, the first 6 months, the chances of infective endocarditis are relatively higher. So we would like to give antibiotic prophylaxis to the person before he goes in for a dental procedure. Then if a person has had, point number 6 and 7 are relatively, I would say, easier to remember. Like a person is having a transcatheter pulmonic valve deployment. I've already talked about aortic valve, a TAVR deployed in a person, but this time I'm talking about a transcatheter pulmonic valve, or let me say a pulmonary artery conduit being deployed in a patient. So the main message is that if we are doing any procedure with respect to deployment of conduit or changing the heart valves, we need to be a little up in our aggression with respect to preventing further damage to this conduit that has been deployed in the heart of the patient. And part number 7 would be, I would say, just for the sake of completion, because the term here which is given in textbooks is, I'm not talking about valvuloplasty, I'm talking about valvulopathy. And this valvulopathy, which is seen after cardiac, the chap has already had a cardiac transplantation, and there's a valvulopathy process or damage to the heart valve seen after cardiac transplantation. Then again, prophylaxis would be required. What prophylaxis would be required? We'll be using amoxicillin. Obviously, as compared to ampicillin, amoxicillin will be having lesser chances of development of diarrhea. We'll be using 2 grams here. That's a substantially high dose. That's why I said, as compared to ampicillin, more comfortable to use 2 grams per orally, and this would be given 1 hour before the procedure. Nobody would ask you the dose. Nobody will ask you how many hours before the procedure, because the procedure can again vary, because the waiting time at the dentist can be, he might take more time on one case, so we really can't. But our main objective is peak antibiotic concentration should be present in the blood when maybe a root canal treatment or a dental extraction is being done in these patients with the following scenarios. And even if you don't remember all of this, I can say question will always be all except. And in majority of the previous year questions, all he has done is he tried to make it sound hi-fi by saying valvuloplasty after transplantation, prosthetic valve, LVAD, and then the last option was the simple ASD. Most guys said, sir, we did not even have to go through those complicated terms that he had used, like unrepaired congenital heart disease, repaired congenital in the first 6 months. He said we could pick it up the question easily because AST had sensitized you already, would be having less chances or least chances of endocarditis because of a lesser pressure gradient. So these are the details that I would like you to remember for this topic. And keep hammering, keep the pressure on. I know that it took a while for you to cover this topic, but I'm sure that once you do this and you get a visual memory of all those aspects that I've talked about, bacteriological information, organism specific approach, modified Dukes criteria, you would be on your way to get good marks in the final exams. Thank you.